So now we've done the discussion on ECG leads, axis, cardiac axis, the bundle branch block, and the right and left ventricular hypertrophy. Now we proceed on to the QRS complex. QRX, what's QRS? QRS is the ventricular depolarization. And what's the duration? It's 0.06 to 0.1 seconds or less than 3 small square. 1 small square is 0.04 seconds. And what is ventricular repolarization? ST is ventricular repolarization and it's 0.32 seconds. And what's QT? QT is ventricular depolarization plus ventricular repolarization and is 0.43 seconds. So QRS is QT minus ST. QRS is equal to 0.43 minus 0.32, that's 0.1 second. So how the depolarization spreads? First, there is depolarization of the interventricular septum, then the right ventricle, and then the left ventricle. So this is the sequence of events in depolarization. How the depolarization spreads in the ventricles? It spreads from endocardium to epicardium. So in which direction the repolarization proceeds? The repolarization proceeds in the opposite direction to depolarization, that is from epicardium to endocardium. The ST segment, T wave and the U wave represents the ventricular repolarization, and the U wave also represents the papillary muscles. Or what's the J point? J point is the junction between the end of the QRS and the beginning of the S. So the three parts of the QRS are Q, R, and S. What's Q? Q is the first negative deflection of the QRS complex and represents the septal depolarization. The R represents the depolarization of the anterior part of the ventricles, and the S represents the depolarization of the base of the ventricles. What's a positive QRS complex? The largest positive R is larger than the largest negative Q or S. To what phase of the cardiac muscle action potential belongs to the QRS? The phase 0 is QRS and phase 2 is ST. So the phase 0 is sodium influx and phase 2 is calcium. So the hyperkalemia and flecainide, they decrease the phase 0 and QRS duration, whereas amiodarone and hypocalcemia increase the phase 2 and increase QT interval, whereas digitalis and hypercalcemia, they decrease the phase 2. So what may happen to the QRS complex? It may be tall, it may be low, may be wide, narrow, or notch. What's the most common cause of a tall QRS complex? Left ventricular hypertrophy is the most common cause of a tall QRS complex. And a common cause of low amplitude QRS is a pericardial effusion or infiltrative myocardial diseases. The narrow QRS and a wide QRS. The narrow QRS usually is supraventricular in origin, and a wide QRS originates in the ventricles. So what are the causes of a narrow QRS? The narrow QRS normally may occur in children, and it may also occur in exercise. The narrow QRS also occurs in the sinus tachycardia, and it also occurs in AVNRT, atrioventricular nodal re-entry tachycardia. See here, and this is also atrioventricular nodal re-entry tachycardia. The other cause is junctional rhythm or junctional tachycardia. So this is junctional or nodal tachycardia. The other causes are multifocal atrial tachycardia, atrial fibrillation, and atrial flutter, cardiac tamponade, and acute MI with myocardial rupture. The pulmonary causes of narrow QRS are tension pneumothorax and pulmonary embolism. Wide QRS complex, more than 0.1 seconds. What are the causes of a wide QRS complex? Bundle branch block, hyperkalemia, Wolff-Parkinson-White syndrome. In Wolff-Parkinson-White syndrome, there is a wide QRS complex with a notch or slurring at the beginning of the upstroke of the QRS, and there is a short PR interval. The right and left bundle branch block, and remember the formula for the right is marrow. Remember that M-shaped or notch or rabbit ear with T inversion in left bundle branch block, and W shape and T inversion in chest lead V1 in right bundle branch block. Abnormal depolarization results in abnormal repolarization, and then therefore ST deviation can be expected. So the wide QRS complex may be of two types, a regular and an irregular QRS complex. So the regular QRS, wide QRS complex or WCDs, what's the most common cause? The most common cause is ventricular tachycardia. So VTAC is the most common cause of a regular wide QRS tachycardia. See here, this is what is ventricular tachycardia, dead regular. Ventricular tachycardia, and then left ventricular hypertrophy. Remember, echocardiography is the gold standard to determine the ventricular size and not the ECG. But the criteria is S in V2 plus R in V5 is more than 35 after the age of 35 usually, and there is ST depression or T inversion, that is known, that's LV strain pattern. And which limb lead shows the left ventricular hypertrophy? R in ABL plus S in V3 is more than 25. So as unusually tall QRS, most common cause is left ventricular hypertrophy, and LVH is often associated with left bundle branch block. Here is the R in V1, S in V2 plus R in V5 is more than 35 with the strain pattern, LV strain pattern, T inversion, ST depression. And what are the criteria for right ventricular hypertrophy? This is also a cause of wide bundle branch block. R in V1 is more than 7, or R2S ratio is V1. I'm just repeating it. We already have discussed in the other videos. R in V1 plus S in V5 is more than 11, and there is a right axis deviation with a R negative in long lead 1, and there is a P pulmonale. The next cause of wide QRS is acute myocardial infarction with pump failure. See, this is the difference between in acute myocardial infarction with myocardial rupture was the narrow QRS, but here in acute MI with pump failure it causes wide QRS complex. So the rupture causes narrow QRS, and pump failure causes wide QRS complexes. The supraventricular tachycardia with aberrancy, with bundle branch block or with accessory pathways also cause wide QRS complex. Amongst the electrolytes are hyperkalemia and hypermagnesemia. The hyperkalemia, when it's about is more than 5, it causes tall peak T waves, and when it's more than 8, it causes very wide QRS complex with ventricular fibrillation and asystole. The tricyclic, amongst the drug tricyclic antidepressants, they cause wide QRS complex tachycardia. What drugs are the tricyclic antidepressants? They are imipramine, amitriptyline, and nortriptyline are the examples of the block. How do they work? They block the reuptake of noradrenaline and serotonin at the transporter sites. They are the sodium channel blockers and they produce wide QRS. Plus, the tricyclic antidepressant wide QRS has a positive R in AVR. You remember the AVR is the lead, which is different from the other lead, but here is a long positive R in AVR in tricyclic antidepressant poisoning. And what are the other drugs that cause wide QRS? Cocaine, phenothiazine, lithium. Among the antihistamine, diphenhydramine, it causes, and also the quinidine like effects produced by sodium channel blockers. They also cause wide QRS complex. The other causes of wide complex are intraventricular conduction delays, ventricular ectopics, hypothermia, and a pacemaker. Supraventricular tachycardia with aberrancy, bundle branch block, or with delayed conduction due to drugs and electrolyte. All of them they cause wide QRS. The third degree heart block, AV block, also causes wide QRS complex and premature ventricular contractions. Remember, no P in PVC, no preceding P in a PVC. And idioventricular rhythm, wide QRS, dilated cardiomyopathy. We already discussed Wolff Parkinson, which has a delta wave, arrhythmogenic cardiac conditions, pacemaker generated, already done. Brugada syndrome, we'll discuss it in a moment. Then when we come to the wide complex tachycardia with an irregular QRS. So what are the causes of that? Atrial fibrillation, flutter, and bundle branch block. So these are the causes of wide irregular QRS, atrial fibrillation and atrial flutter and bundle branch block. Remember when we discussed that earlier that atrial fibrillation and flutter cause narrow QRS, but if there is an aberrancy or block, then it causes a wide QRS complex. The other cause of the wide QRS is torsi di pontis. We'll discuss it later. In which leads T wave may be inverted normally. T wave inversion in chest leads 1, 2, and 3 are normal variant in healthy young adult women. The U wave has the same polarity as the T wave, and increase in U wave is caused by certain drugs. And those drugs are sotalol, procainamide, disopyramide, amiodarone, and hyperkalemia. A prominent U wave occurs in torsi di pontis. The S3 segment depression during exercise testing represents ischemia and depends partly on prior probability of coronary artery disease. Why there is tachycardia in ischemia and in hypokalemia? Or what's the mechanism of tachycardia in ischemia? In ischemia, there is decreased activity of sodium-potassium ATPase that leads to decrease in repolarization current. That increases the phase 4 diastolic depolarization and that leads to increased firing of the pacemaker. The left atrial abnormality, enlargement, and signs of right ventricular hypertrophy suggest mitral stenosis. Low voltage with sinus tachycardia raises the possibility of pericardial tamponade or chronic obstructive lung disease. What's the feature of tricyclic antidepressant overdose? Sinus tachycardia with QRS and T prolongation, especially with mental status changes. What are the ECG findings in chronic renal failure? So what happens in chronic renal failure, that there is hyperkalemia and hypocalcemia and hypertension. So if there is a hyperkalemia, there will be a peak T wave, and due to hypocalcemia, the long QT due to ST segment lengthening, and number 3, because of hypertension, there will be features of left ventricular hypertrophy. How about QRS and in VTAC? That occurs in myocardial infarction, cardiomyopathy, and myocarditis. The monomorphic VTAC occurs in absence of any structural heart disease. And what's polymorphic VTAC? The polymorphic is variable from beat to beat and occur in ischemia, myocarditis, and increased QT interval. How do you differentiate between a sustained and non-sustained VTAC? It is the 30 seconds duration that differentiates sustained from a non-sustained VTAC.